Welcome everyone to session 4. I hope that you are still prepared to continue hearing a very interesting session. It will be about health technology assessment and value-based healthcare. In this fourth session, I will introduce you a colleague that works with diabetes, Dr. Ronaldo Pineda Wieselberg, Vice President of Association of Juvenile Diabetes Brazil, and we will also have Aurelio Mejia, Director of Regulation, Ministry of Commerce, Industry and Tourism from Colombia, and Professor Alice Andrews, Director of Education, Value Institute for Health and Care, University of Texas at Austin. You can find their full biographies on the official first Virtual Latin America Patients Congress page on YAPO's website. Before we get started, remember to use the Q&A tab in the auditorium to submit questions to the speakers. Enjoy the session. Now I invite you, Dr. Ronaldo Pineda Wieselberg, our moderator. Thank you, Steffi. It's a great pleasure to be here with you. I believe that we already know that health and universal coverage in accordance with the World Health Organization, it's very important, and mostly right after COVID-19. So how are we going to provide services, technology, health devices that are innovative based on evidence, of course, to make sure that countries can extend their universal health coverage until 2030, providing coverage for most part of the population, offering health services that are more appropriate and that can also contribute to reduce the cost. So we need to decide how reimbursement will work. This session aims to create awareness about the assessment of sanitary technology or health technology in the specific conditions of Latin American countries and how can they participate in this process, as well as analyzing how people with chronic conditions and the governments can work together in the decision-making process of this reimbursement so they can assure universal coverage until 2030 in an efficient and effective way, as we have access to different health services and devices, as well as innovative processes. So we invite you once again to send the question through the Q&A session that you can see in your screen. So now I will invite to the floor Mr. Aurelio. Thank you very much. Thank you for the invitation. I hope that you can hear me well. Yes, it's working okay. Perfect. I'd like to express my gratitude for the invitation. The presentation I have for today will address briefly the context of health technology assessment in our region, and also about the decision-making processes. Just 1 second. Is it better now, the audio? The general process of the current participation of patients in the technology assessment processes. First of all, I'm an employee of the Ministry of Trade, Industry and Tourism, and also I'm a professor in the University of Los Andes. Of course, the opinion expressed in this presentation are not related to any of those institutions. Next slide, please. Here is the agenda of the presentation. We'll talk about political context, institutional development, and the main challenges. This is the discussion. I will get it started today with you. Next slide, please. Next, I won't talk about the previous slide that explains some general risks. We already know that many countries, generally speaking, need to grant coverage for their population, and they are trying to decide how they can finance the technology they are developing. And it's important to try and find how coverage will go alongside with the budget, the possibility that families have, and also in accordance with health services. In order to work with this, countries have included systematically this in the process. It's a process that assesses the consequences and the different costs, stability, and other aspects. It has to do with financing and adoption of those technologies. It's important that we consider this process as one pillar within a system. This was elaborated by a specific institution that illustrates very well the whole concept and the whole process of decision making. And it applies regardless the health system we're talking about. As you may see here, in this first part, the yellow part, you can see the approval for commercialization. Later on, an authority, commonly the health ministry in each country, will decide on this. They are responsible for deciding from the set of possible medicines which will be approved to start being sold. Then we have the evaluation, the third column. Commonly, it's an external authority in charge of this decision. They will analyze the different consequences, the different costs, and organizational aspects, among others, of those technologies. Finally, right after this evaluation, you will have a deliberation process with the participation of different actors. And specifically, some actors should play a very important role here because we start to combine the results of the evaluation process with the values and the aspirations of society. Also, responsibilities that decision-making persons have, and these should be a specific space to make a decision. Commonly, an authority, it could be the health ministry, will decide on this. That's why we have this decision column, the pink one. Then we have a second phase, which is about claims, and then monitoring, the final one. This is very important, and as we are talking about evaluation processes, we need to highlight that this is a prioritization process as well. Next slide, please. This was recognized by different countries as something key, and PAHO issued a resolution to every state member about the assessment of health technologies. As you may see here, this resolution promotes the strengthening of institutional agreements, trying also to boost transparency, exchange, allowing participation, and how this can impact the decision-making process. Finally, The aim of this resolution is that states promote rational use of technologies. Next slide, please. How was the process and the institutional development in Latin America when talking about technology assessment? Next slide. As you may see here, in this slide, we have the institutional evolution of those technologies from the beginning of the 90s. We can see some local units and some individual efforts of evaluation in America. Specifically, there was an initiative called Nevelet. Then, at the beginning of the next century and in the first 10 years, some specific entities or organizations started to work in different countries. We have some in Uruguay, Colombia, Chile, Mexico, Brazil, and those organizations started to create specific units in charge of evaluation processes and to help the decision-making process for those governments. Then we started to see regional processes at the level of the Common Market of the South and other international associations with the objective of creating spaces in the region or even international spaces to exchange. Then we started to see an institutional development with different organisms in charge of those processes. The scientific community and the academic community started to promote different methodological aspects of technology evaluation. During last years, we started to see patients' participation as something key. During the first years, in the region, we saw or we realized specifically that there are greater opportunities for financing, creating legislation to provide more stability to those processes. Patients' associations are training their members on different techniques and in different processes so that they can have an active participation in technology evaluation. Next slide, please. During last years, we saw many processes, formal processes, but in those countries, there are still some development in the academic sector that are more formal, and in some countries in the region, we still have a lot of room for improvement, specifically in Latin America. Next slide, please. Next. So now I want to talk about challenges, specifically the challenges we have about technology evaluation and patients' participation. Next. It's even more frequent to use data from real life because we have more data available. This requires more technical capacities in order to use this information. So here, the second point is specifically about the articulation of the participation of the patients because they are the ones that can provide this information. Now we have new technical needs on how to include this input data that patients are providing us in the evaluation process. There are other aspects in the evaluation process, such as establishing the technology efficiency, the cost efficiency rate as well, and how we can try to define a possibility in which the price of medicines, of drugs, are in accordance with the technology. This is the other point in which patients need to understand the value that this has and how we can make this visible. Sometimes it's not easy to express this. So as you may know, we have a lot of things to do, a lot ahead of us, specifically from the patients' organizations, the patient associations, because we need to include patients systematically in the evaluation process. In the region specifically, and this is the last part, so let's move to the next slide, please. And as I was saying, in the region, we have many challenges. Specifically, some of them are about the participation of the actors and the transparency in the process. So we can try to define clearly the moment, the specific moment, and how. So, as we were talking about the evaluation process before and the technology evaluation, we have different spaces, different steps, so it's important to establish clearly in which discussion spaces the patient will take part, which is the correct moment, how they should participate, and whom. Specifically in the decision-making process, as we are building the process, it's important to consider that we should have representatives from patients association that can talk generally with the whole group of patients and that are able to express the needs of the citizens and other patients. But it's also important to consider that there are some other participation spaces from the customers. And what I need here is to have different patients with different conditions and with different interests, because what I need is to know the experience of those different diseases, the limitations, the expectations, and the results, as this is valid or not by the patients. So here we can take at least that we have two big or two important spaces in which the patients should take part. We have even more and more recognition nowadays, but it's very important to make this clear, to make it explicit in the evaluation processes in each country. So we have probably a macro process and then other processes below. And of course, patients organizations, patients associations should participate in those evaluation processes. So I would like to finish my presentation with some takeaways. Next slide, please. Next. Technology assessment or evaluation is even more and more present in political discussions in the region, and we are now able to acknowledge the relevance. However, the implementation has been slow and not systematic. There is a gap and a growing gap between what medicine can do and what societies can finance. So we really don't know in an appropriate way the different processes in which we could participate. Anyways, there are even more and more patients organizations that have a very well structured and are very well organized. And there is another challenge that we will continue facing in the future, and that it's more and more important for the region, is that, as I was saying, the gap continue growing and will continue growing. In this regard, it's more and more important that we have different processes and we can make decisions that allow us to use efficiently the available resources. Thank you very much for your attention. So now I give the floor to the other members of the panel. Thank you very much, Aurelio. I believe that we have many questions for the discussion panel. So now I'll invite the next speaker, Professor Alice Andrews. Welcome, Alice. The floor is yours.
Thank you so much. Thank you for the opportunity to speak with you today about how a value-based approach can transform health and care. So I'm Alice Andrews. I'm the Director of Education and Faculty at the Value Institute for Health and Care in Austin, Texas, in the USA. I'm always aware of the irony of an American speaking to you about healthcare transformation. The US lags behind all countries in care access, and the way we are really exceptional is that we spend more money on healthcare than all other nations, and that's not something to which I personally aspire. But it does give our group an incentive to learn from the best around the world about how to transform healthcare. Next slide, please. Our institute, the Value Institute for Health and Care, was founded by Professor Elizabeth Teisberg, who co-wrote the book Redefining Healthcare, which really started the value conversation back in 2006. Our organization has a three-part mission. We work with clinical teams that are engaged in transformation around the world. We have educational programs from short couple-day programs to a full-year master's degree in healthcare transformation, but primarily, we're a place to bring together healthcare innovators across the world to learn from and with each other. And I'll give you my contact information at the end. I'm happy to talk more about your work and connect you to our community. Because interestingly, despite our different funding methods, we all share concerns about whether or not we're improving the health of our people. We talk about access, but the question is, access to what? For the most part, in our countries, we pay for what is done, not what is achieved. We pay for outputs, not outcomes. Next slide, please. So why is this the case? Why do we focus on what we do, on our activity, not the result? Healthcare is critical. Everyone has a story, patients, clinicians, families. Why would something so important to so many problems persist? It isn't a lack of attention. We have shared goals, quality of life, dignity of death. It's not a lack of brain power. We have lots of smart, caring, hardworking people, but the problems persist. Healthcare outcomes remain highly variable, costs are increasing, and innovation tends to happen at a snail's pace. So why is this? We need to reset the compass. Next slide, please. We need to move towards better health for each and every person, towards what we achieve, not just what we do. We often think about healthcare as treatment rather than as care that achieves health. Even safety and quality, these should be the baseline, not our aspiration. Patients don't come in saying, it was successful because I didn't get an infection and the doctor washed their hands. Now, don't get me wrong, these are incredibly important. Treatment needs to be safe and respectful, but that should be the baseline. We need systems that make doing the right thing for quality and for safety effortless. But those are not our aspiration. They are not the results of care. Our focus on treatment means we measure at the wrong level. If you have a hospital with great cancer care, but below average cardiac care, is that great? Is it below average? How do you know where to go? It depends, of course. A great hospital or health system for you is one that achieves great results for what you are facing. When we start at the wrong level, we start with the wrong questions. We have to start with patients and relationships. So outcomes that matter to patients is the definition of success that really matters. Next slide, please. This idea that doing more is not the same as the result is not unique to healthcare. Healthcare is what we call an intermediate good, where the result, not the experience, is the purpose. For example, it's summertime in Austin, Texas. I want my air conditioning to work. I need the electricity. That's the intermediate good. But I don't want more electricity. In fact, I'd like to use less. Air travel is another example. Very few customers are there for the experience, especially these days. You need to get somewhere. That's the purpose of air travel. A cheap ticket to the wrong destination is not a bargain. If you have a meeting in Mexico City, it's not okay if the plane leaves you in Cancun and you have to arrange to get back the rest of the way yourself. Of course, experience still matters. You want your healthcare to be clean and comfortable, and you want good parking and food, but you're not there to get the experience of a luxury hotel. Again, the experience, respect, dignity, safety, and compassion should be the floor in healthcare, not our stretch goal. Next slide, please. So that brings us to the value equation. I'm sorry, next slide, please. The value equation. So many of you may have seen this. It's the idea that value equals the change in outcomes over costs. Sounds really simple. However, the focus for the most part has been on the denominator. How do we reduce costs? How do we engage in value-based contracting? Honestly, if cost reduction were our main goal, we could just give people painkillers and be compassionate and say we're done. And just reducing the cost doesn't improve the outcome. If there's no change in outcomes, value is zero, even if the cost is low or very efficient. So healthcare is really created one person at a time when health outcomes improve. It's about holistically achieving better health more equitably for more people. Next slide, please. So the previous speaker mentioned gaps. An essential insight of the value perspective is that there are many, many gaps in healthcare and in healthcare delivery. Many people are served ineffectively or inappropriately. And these gaps provide opportunities to transform health and care. There are many ways people are underserved, some of which involve a lot of spending and treatments, but for the wrong things or at the wrong time or redundantly. For example, frail elders often spend too much time in the hospital or nursing homes when better care could keep them at home or independent, which also would be less expensive. People who are misdiagnosed may get treatments that are all waste or harm. And people without a way to pay for early stage care may not get treatment until they need emergency care. Again, that's also a lot more expensive. People with chronic conditions like diabetes may have so many different parts of their care that they can't adhere. It becomes chaotic and their disease progresses more or faster than it might. And last year, but important, there's evidence across all of our countries about care disparities and a lack of equity. If we can measure outcomes for every patient, we'll unmask disparities and really be forced to change them. Remember, it's not just about access. We need to make sure patients have access to solutions that improve health. So high-value care helps. It's more effective. It often occurs earlier in the cycle and usually is more holistic. It may take into account more than one medical aspect at once. For example, the mental health or other services that are not traditionally medical. It provides solutions around patient needs. Next slide, please. So how do we measure outcomes? Today, the most common question to gauge success is asking, how were we? How was our parking? How was our food? How are the wait times? Things like using net promoter scores. But this is healthcare. The real question is, how are you? Did we help? Are you meeting your goals in your life? This is the essence of high-value care. And if we can do this, if we can answer that question, we've got it right. Next slide, please. So what does that kind of measurement look like? We always start with talking to patients with similar medical conditions to understand what matters to them. And there are a lot of specific things you can measure. However, after more than 10 years of working with patients and families on what health means and which outcomes matter, we've recognized that while different individuals have different goals, outcomes that matter robustly fall into three categories. The first is capability. That's the ability patients have to do what matters to them. Better functional outcomes. It's being able to use your feet if you have diabetes, whether that's to go dancing or to go hunting, but using your feet. It's regaining shoulder mobility after an orthopedic procedure. It's making sure that young adults diagnosed with cancer are told and understand the impact their treatments will have on fertility, which sadly doesn't always happen. In addition to capability, we need to measure comfort, helping to manage the physical suffering, the emotional angst, the depression, and the anxiety that comes along with treatment. Can we provide a counselor at the time of diagnosis, not wait until a mental health issue is present? That's a way to manage comfort. And then finally, we need to measure what we call calm. Can life go on during the treatment of disease? Avoiding that chaos that goes with medical treatment. Can you manage your family? Can you manage your life? Are you not worried about losing your job or missing appointments due to a lack of childcare? Notice this framing of capability, comfort, and calm is a positive framing of the measurement of outcomes. It's about what you did, not what you didn't do. When you start with capability, comfort, and calm, you're starting with patients where they are. This type of measurement is inherently deeply patient-centric. It's inherently deeply relationship-centered, a way to communicate earnest empathy. Next slide, please. Again, because value is created at the level of individual patients when a patient's health improves. So to transform healthcare, we need to build relationship-centered solutions that anticipate patient needs. Relationship-centered care requires a system that, of course, builds relationships between clinicians and their patients, and also supports relationships among members of the clinical team. The team should be organized around what matters to patients and how they interact to make that a reality. That leads to value, and it's an issue of system design. Better designed care gives caregivers more time with patients and more support for relationships. Clinicians who measure outcomes that matter to patients demonstrate empathy. Patients can see that what matters to them is also motivating their caregivers. And as we focus on what's right for patients, we return the goal of healthcare to its purpose, helping people lead their lives. This type of care supports professionalism. The pandemic's put enormous strain on the resilience of our healthcare teams, and it was stressed before. When our clinics at the University of Texas at Austin started measuring capability, comfort, and calm for patients, clinicians wanted to measure it for themselves. They felt it could be a way to help reduce burnout and moral injury that comes from the stress they've been under. So providing relationship-centered care that puts health outcomes that matter to patients front and center, that focuses on what is achieved with patients rather than what's done to them, supports professionalism. It reconnects healthcare with the purpose, healthcare workers with the purpose of their profession, which is health. It supports resilience and a culture built on relationships and communication so that everyone, healthcare providers, administrators, and patients are working towards the same goal. None of it's easy. The shift in thinking requires a lot of thought and effort. But ultimately, value is about focusing on the purpose of helping those we serve and supporting the professionalism of those we serve. Next slide, please. So I just want to say thank you. And here's my contact information and contact for our institute. Happy to continue the conversation. Thank you so much.
Thank you very much, Professor Alice. I'm sorry, I was about to speak in English, but I forgot I should speak in Spanish. I would like to express my gratitude to all the delegates. We have 322 participants in this discussion panel, so thank you very much, everyone. We have two questions. We can get started with Aurelio. The question goes like this. In order to engage population, it's necessary that they know which technologies can be included in the health system. How can we inform to the population which technologies will provide a better cost efficiency rate without increasing the budget in the context of a public health system? Well, so I'd like to highlight two aspects. First, populations should get to know the different mechanisms and the regulators in the training process so that the representatives of the patients associations or organizations know in which moment they can start participating. This is a task that should be in our scope and also in the scope of governments. Commonly, we should have legislation tools or other mechanisms, but it's quite common that patients don't know how they can participate. So I believe we should unify our efforts. The second part of the question, it's something that I believe it's very important, and agencies haven't had a good performance. Commonly in those studies or in those research, they present reports, but they really haven't tried to tackle how to implement those technical aspects and how to translate this in a common language. I believe that technology companies or agencies should invest more time and money in designing different brochures or reports that are more easygoing, more easy to read, oriented to the patients. There are different international forums of patients that have other tools or mechanisms that make information more accessible for patients. I believe that this is something very important to make sure visibility is granted because we do have the information, but this translation mechanism for the patients is not working. Thank you very much. I believe that we should also try to propose a solution based on the relationship between the healthcare workers and the patients, as Professor Alice talked about. We should continue now with the next question that goes like this. How can we work with the value of different interventions for different patients as the benefits is subjective for the families and individuals? And how can we work in those cases when there are different diseases at the same time, such as cancer, obesity, diabetes, hypertension, anxiety? Professor Alice, the floor is yours.
Great, thank you. That's a great question. So let me do the second part first. There are, of course, many different conditions and what people are trying to achieve with cancer versus diabetes. I mean, again, people are trying to work towards health. So I will say that for each medical condition, you need to have the measures that matter for that, but they need to be outcomes-focused measures. So for example, in orthopedics, there are very good measures for physical function after an orthopedic procedure. But even with that, most clinicians don't use those. So each medical area should have the measures that they know matter to their patients. But then this idea of capability, comfort, and calm is bringing the measures together. So across conditions at our clinic, they're comparing how patients feel overall. And that's where those measures come in and are really useful. The thing that's also, so you can use it as a general measure that you can compare across areas. The thing that's really important, though, is starting with talking to patients. So this idea of it being subjective, ultimately, the patient is the person who knows how they feel about the care that they get. We start our work by bringing together small groups of patients, in this case with similar medical conditions, for example, early stage breast cancer, and let them talk like a focus group, to talk to each other. What's a good day with your illness? What's a bad day? What gets in the way? What helps? And those conversations lead to insights often things that the clinical team was not aware of how important they were to patients. For example, in this breast cancer example, we heard over and over again that after survival, of course, which is the most important outcome, women were very concerned about cognitive capacity from chemotherapy. And at the time, at least, there were no centers that were measuring the impact of chemotherapy on cognitive functioning, and there weren't resources for women to help them with this. So the subjectivity, you can have your other objective measures that you use, but making sure you're starting where patients are to understand what matters to them, because if you don't, you're not going to know what gets in the way of them achieving the care the clinical team thinks is important. And I'll stop there. Happy to share more.
Muchas gracias, profesor Andrews. Tenemos otra cuestión para vos.
I'm sorry, was that for me? The interpreter wasn't sharing the. So
Okay, I can speak in English because the question came originally in English. So, is there a risk of treatment with high value in patient's perspective to be low value in terms of clinical results or cost effective? How to decide which to offer in this situation?
Yeah, boy, we could have a whole day conversation about that. So, low value care, if you can measure outcomes for every single person, you can start to say what is high value care, what is low value care. Today, patients may want things that they think are high value because we don't have the data to show them this is low value, this is not going to help you in the way you think it's going to help you. So there's an education piece of it there. I think it's been interesting with the pandemic, and because when services were all shut down, we started to identify what are things that are low value, and patients started to think about, maybe I don't have to go in every 3 months for my chronic condition checkup. So I don't have a specific answer for you. I just think this is a real challenge of education. But again, we keep going back to, what do patients want to get out of their health? That's achievable. I mean, somebody who is, quite elderly, who has a hip fracture, like they're not going to be a long distance runner. But within that idea of what is possible for them, are we measuring what matters to them?
I'd like to add a comment. I'm sure I agree that we could start discussing this and it will take us the whole day. And of course, there is no single answer because it depends on each case. But we should, at the beginning, define why this could be a divergence. Maybe the cost of medicines or drugs it's high, and probably we will expect that this is a value that is accessible for patients. But if it's not, probably we didn't gather the whole amount of evidence before that will allow us to decide the better value for this. This is the first part. And the second one is about the cost efficiency rate. Probably it could be associated to the price and also the way we could try to solve this divergence with other experts or with other providers. We could try and search for a different partner, for a different provider that could offer us what we need, because we are talking about decisions that have an impact in the whole society. And in third place, let me give you another example. Let's suppose that this divergence is about uncertainty in clinical results or clinical outcomes, and we need to work in the communication because we have to make sure that patients understand what those results are about and what they really need, because sometimes they could have a specific benefit from a specific therapy or treatment, but they haven't realized that or they think otherwise. So communication is key. I really liked the answer to this question. I believe that this is very hard because we cannot compare different health conditions, how we can compare oranges and apples. Those are different conditions. For example, in Brazil, we have a specific committee, a committee that in many occasions can listen to the voice of the population. It has less weight in comparison with technical issues. So we have huge difficulties, and I believe that this is present in the whole continent, in all Latin America. We have two more questions. One of them, it's about working towards the Sustainable Development Goal number 3 of United Nations, and if this will help somehow the health sector. And the answer would be yes, because the goal 3.4 is exactly about this goal of reducing till 2030 in 1/3 premature mortality due to non-communicable diseases, treatment, trying to promote also health, mental health, and well-being. And we need to propose other health interventions. I believe that we can share our opinions about this question. What role is there of patient-reported outcomes in decision making? Maybe we can get started with Professor Andrews.
Absolutely. I think that patient-reported outcomes need to be included in decision-making. I mean, decision-making is a very broad topic, though, so it sort of depends how you're thinking about it. But patients need to be included at every stage of any of these things that we're saying we're going to work to achieve. You know, we often get caught up in new things for the sake of new things. So we're all wanting to make sure that we're taking the data that we're getting these days and turning it into information that becomes knowledge. But we have to make sure that we're always asking ourselves this idea of the compass. Are we headed in the direction? Are we working on things that are going to make outcomes better for patients? And you can't make those decisions if you don't have patients included at every step of the way.
I agree with Professor Andrews' comment. I believe that some agencies are facing other difficulties when they don't have availability of data, of information in some cases. Sometimes we only have information that was reported by the physicians, but this is not enough. And in some cases, we could use the information reported by patients. We should try to find out which are the better mechanisms to gather and systematize the information that patients can report. It won't be easy. In terms of cost efficiency, we have always acknowledged that patients have a key role because they are the ones that can provide the most true information about how they're experiencing the conditions they're experiencing. Just to add another comment, I would like to share that when we think about informed results, we have two different scenarios. Clinical practice, on one hand, where we have the health worker with the patient with a specific condition, and the Informed result is key in order to make a decision. On the other hand, when we're talking about a public health scenario, we need to bear in mind that in many occasions, what is good for someone is not good for everyone. We have many indicators that try to offer the best for every person. Essentially, it's something extremely difficult. Of course, we could continue talking about this topic for hours and hours. And here we have the final question because we are running out of time on this panel. How can we promote alternative medicine as something complementary in patient therapy or treatment? Maybe we can get it started with Aurelio. This is not something I'm an expert on, but I'd like to mention that as we are assessing alternative medicine, or the same way we value traditional medicine, our therapies, we could also question this. In some countries, some medicines based on natural products are already in the public health system. We're already included because they know it works. We need to generate good evidence that can back up this type of therapy. Professor Andres?
And I'll speak to this in a different way too, because I also am not an expert on alternative therapies, but one of the points I want to emphasize in this idea of talking to patients about what matters to them, you will hear the alternative therapies that people have used and liked, and maybe that's a role to look into that more. But alternative therapies can also be alternative services. So there may be services you don't expect but help patients with the clinical goals. We have an example of a clinic in Louisiana here in the US where they were working with patients who were very obese. And one woman wanted to get pregnant and had very high blood sugar and couldn't get pregnant. And it actually turned out in the conversation with her that her mother had been in hospice and loved donuts. And so she would bring donuts to her mother every week. But when her mother died, she was still in that habit of eating, 6 donuts and picking them up all the time. And so, yeah, she needed to work on her exercise and her food intake, but they got her a grief counselor to help process the grief she was feeling from her mother's death and to sort of get over that emotional part of that excess eating. So that's just a little tiny example, but understanding the whole range of services and potentially alternative therapies and medicines that play into helping patients achieve what even the clinical people feel are the appropriate goals.
Algo también para complementar.
Also, alternative therapy, it's not necessarily something that should have scientific evidence that it's better to someone, but if it's not doing anything bad or producing any bad consequences, it's okay. I was in Brazil, for example, there's something very popular, such as teas, for example, to treat diabetes. We are not so sure that this is not bringing benefits, but we also don't know for sure that this won't bring any bad consequences for the patient. So it's very hard. First of all, it's important to know that probably this won't bring any benefits. But secondly, it could lead to misuse or it could lead to bad consequences. So every part should be included in this process and in this decision. So now this is the end of our panel. This was the last question. I'd like to thank all participants, delegates, and all the questions that you sent. So now I give the floor to Estefania once again. Let's continue enjoying our Congress. Thank you very much. Congratulations. Have a good day. Thank you all for this great session. I'm still writing down some things, and I have some words such as advocacy, participation, efficiency, investment, having voice, getting to know the context of people that live with a chronic condition. With a chronic condition, we have a context and environment surrounding us, and this is something key when we're talking about health. And let me share with you that we have a higher number of participants, 336 participants in our Congress, so we are thrilled. Now we will have a 1 hour break and we'll be back at 1:30 p.m. Mexico time. So this break will be to have lunch or to have also some snacks depending on the time zone. And we'll be seeing each other again in the fifth session that it's about rare diseases and people who experience those rare diseases. While we are in the break, you can download your certificate, you can take some pictures and share this on social media using hashtag LAPC 2022 and hashtag Congreso Pacientes Latam. We will feature every post, every comment, everything that you share in our social media booth that we have in the lobby and our profiles. We also have the exhibit hall in which YAPO members included different information. You can talk to representatives in real life. You can also learn about the work of YAPO members in Latin America through the videos that will be available in the auditorium during the breaks of the event. Thank you very much, everyone. We will see each other again in 1 hour.